Are you gonna, or how do you want to do this?
Actually, I have made a presentation, ma'am, here. I would like to share it with you.
Yes, that would be perfect. Okay, good. Okay.
Fine. I have just now screenshot my PPT, ma'am. Is it okay with you, ma'am?
Okay, I can see it fine.
Okay. So here is the case report of the case I am presenting, ma'am. She's a 20-year-old female.
Okay, can I interrupt you right here? This was my problem, is you don't give a narrative. She's a 20-year-old female who has a history of lupus. I mean, what is it? Was she previously in excellent health? I mean, who is this woman?
Okay. She is a young student, ma'am, pursuing her degrees. Previously healthy kid. Like, and she has a history of only childhood infections. That too not
Of what kind of, I'm sorry, of what?
History of childhood respiratory tract infection, ma'am, when she was kind of neonate. But rather her adolescent age was fine, ma'am, without any illness.
Okay, so you really, so that's how you need to establish that she was in excellent state of health, other than, you know, as a neonate having these infections. And then when she had the fever, so she was in excellent health until 15 days ago when she had the onset of fever. Okay, you're going to give me this. Okay, fever.
Okay, ma'am. So the fever was like, it started 15 days back, ma'am. It was low grade kind of intermittent type, but we couldn't, she couldn't localize based on her symptomatology, ma'am. No burning sensation, no headache, or and there is a source of sepsis or source of infection could not be localized.
Well, no, you don't know that she has infection, but this is highly unusual for a 20-year-old to come in with swelling of her lower limbs.
Yes.
So you're already telling us that so when you have swelling of the lower limbs, infection is not the first thing that comes to your mind.
Yes.
Okay, and then, so she had no symptoms other than fever and swelling?
Fever, swelling, and she has a hyperpigmented lesion, skin rashes, ma'am, on
That's 10 days, but we're going 15 days. 15 days, you have highly unusual for previously excellent health 20-year-old to present with swelling in her lower limbs. So does she have, is she urinating frequently? Does she have, I mean, she must have had some other symptom to go along with the swelling. You understand what I'm getting at?
Yes, ma'am. She has that easy fatigability and also shortness of breath on exertion, dyspnea on exertion, ma'am. Since this.
Okay, so because you say shortness of breath for 5 days, but now you're saying that it started 15 days ago.
Yes, ma'am.
Okay, so it's important because the story that you tell is how you're able to make a diagnosis. So, okay, so now we have a 20-year-old who has a fever, shortness of breath, and all these other symptoms. Were they even like the decreased urine output?
Yes, ma'am. There was decreased.
That's only for 3 days, but she had swelling for 15 days?
Yes, ma'am. Initially, like she could, it was like when she used to keep some support under her legs, then it was resolving spontaneously, and in prolonged rest, then it was pooling, ma'am.
Okay, but again, for a 20-year-old, you're young, you don't have swelling in your legs.
Yes.
So for a 20-year-old to have any swelling, even if it gets better in the morning, is abnormal. So her history really starts with fever, shortness of breath, and swelling that became progressively more severe.
Yes, ma'am.
Okay, so now the hyperpigmented lesions, those started, 10 days ago. Okay, you can keep going.
Yes, ma'am. So she also had a non-productive cough, ma'am, dry cough with sore throat. After since 7 days, ma'am.
Okay.
And she all the signs of all the symptoms of systemic inflammation like loss of appetite and generalized weakness, malaise.
The malaise was for how long?
It was around for the last 1 week, ma'am. Like since our admission on our presentation.
Okay, well, it still doesn't make sense. If you have a fever, you have malaise. So how could she have a fever? So her illness is at least 2 weeks old.
Yes, ma'am.
So you make it sound like it's a very acute, but it's a subacute illness. So because your differential diagnosis changes whether it's a subacute or acute.
Acute. Yes.
Okay. Okay.
Here I
Okay,
was.
so fever, high grade. Okay, so what medication was she prescribed?
That was a kind of local medication, ma'am, which we contribute to Ayurvedic, which are plant derivative extracts. And,
Okay.
and some local registered practitioner gave unknown medication.
Okay, so whatever it was, it helped her, but then she got these hyperpigmented lesions.
So after that, she developed generalized body swelling, ma'am, with associated with dry cough and loss of appetite and decreased urine output.
Okay, so she's really bad. Okay, you can go on.
Recording in progress.
So this is her presentation, ma'am. These are the hyperpigmented lesions on palms and soles with splinter hemorrhages on her nails, ma'am.
Okay. Okay, I see that. And it looks like she's got pitting edema. Is that what you're showing also on her leg?
Yes, ma'am.
Okay.
So we thought that those are the emboliform embolic lesions, ma'am, on the skin of soles and palms, which are painless. And also the pitting edema. A systemic examination here. Okay. So it's a general examination, ma'am. She had also had non-scarring alopecia, and she's pale.
Okay, so let me ask you this, because on her initial presentation, you don't mention anything about the alopecia. So how long has she had the alopecia?
Alopecia is since 2 months, ma'am.
Okay.
She noticed it since 2 months.
Okay. And then does she have Raynaud's?
No features suggestive of Raynaud's, ma'am. No, nothing.
Okay. Any oral ulcers?
No mucosal involvement is there, ma'am.
Okay. Photosensitivity?
No, ma'am.
Okay. So you want to ask all these questions because right now, what is your differential diagnosis? What are you concerned about?
With the background of this history, ma'am, I considered initially it was an infection, infective etiology.
Okay, well, what kind of infection?
Initially it was we thought infective endocarditis, ma'am.
Okay, and how would this woman get endocarditis? Is she's in other excellent health, 20-year-old? Why would she have endocarditis?
Like she had a history of sore throat, ma'am, like 15 days back, or like in this thing also, and she had also a previous history and even clinical examination. She had features of structural heart disease, ma'am. She had a left ventricular hypertrophy.
Oh, okay, so this is not a previously healthy 20-year-old. So what was wrong
Whether
with her heart?
asymptomatic, ma'am.
Asymptomatic, but why? Why would you have an asymptomatic LVH in a 20-year-old?
There could be some other infiltrative disorder or
You understand what I'm saying? So you're presenting a patient, you're not giving the full picture, because she's not a healthy 20-year-old. And if she had, I mean, here her blood pressure is normal, but has she ever seen, when was the last time she saw a doctor?
a couple of months back, ma'am, like to our presentation.
Okay, how about before that? Had she had a routine exam? Has her blood pressure always been normal as far as you know?
Not a kind, ma'am, because they are from rural center, ma'am. So where they are, even they couldn't reach a hospital because they
Okay,
don't
okay.
person.
Okay, forgive me. I live in a different area, so I don't mean to grill you, but I just want to get you thinking. I was in India. I was with Dr. Biswas, so I understand where you're coming from, but you still have to, you know, your brain has to be turning. You got to be thinking, why, even though she's from a rural area. So the story is becoming, you don't have the 20-year-old previously in good health. You've got someone who's sick.
Yes.
And so it's interesting that you said infiltrative lesion, not of LVH. Believe me, I'm a rheumatologist. I'm not a cardiologist. But where we are, the first thing that pops into our mind is hypertension. And again, I mean, she's 20, so she has some type of pre-existing condition, and it sounds like it's chronic. It's not just for 2 weeks that we're dealing with, because to have a structurally abnormal heart has, I don't know how long it takes, but it's not 2 weeks. You see where I'm coming from? Okay, now, and then she's got the non-scarring alopecia. Is she well nourished? You said nourished. Does she look like she's well nourished, or is she looked like she was very thin?
No. Let me project.
Okay, she just has thin hands. Yeah, see, she's thin. You can't tell.
But her build and nourishment was, according to the peers, ma'am, it was good. Not malnourished or pekixic.
No, what? Okay, keep going. Okay, we'll go.
So
Okay.
these are presenting vitals, ma'am. She was quite tachypnic.
Okay, so she's pretty sick. She's got a heart rate of 124 and a respiratory rate of 38. So she's very ill.
So a systemic examination, ma'am, her JVP was elevated and apex feet displaced to medial lateral to mid-clavicular line, 6 intercostal space. On palpation, there was thrill in mitral area, ma'am, and we could hear S3 gallop with a pansystolic murmur in the mitral area. So those were features of mitral regurgitation, and she was presented with the symptoms of heart failure.
Okay.
So even when we did her MMSC, she had a moderate cognitive impairment with hypertonia in all the limbs, ma'am. Like it was like cardioembolic stroke with all the primitive reflexes like palm motor and jaw jerk were present.
So was her family there? Were her parents or family members at the bedside?
Yes, ma'am.
And when were they able to communicate when she started having the cognitive impairment?
Yes, ma'am. But she was like she had an inconsolable cry and inconsolable laugh and with mood disturbances, ma'am.
And when did all of that start?
After admission, ma'am, like after 1 to 2 days after admission in the hospital.
Okay, so this is a new finding.
Yes, ma'am.
Okay.
So these are presenting chest X-ray, ma'am.
Right.
These are showing cardiomegaly and mild pleural effusion. Their EKG. She had a good left ventricular hypertrophy with mitral regurgitation, ma'am.
Okay, so the fact that she has, and again, I'm no cardiologist, but the fact that she has LVH suggests that this is a chronic process.
Yes.
Okay, and then, okay, I'm not good at reading echoes and stuff like this. So did they see any of the evidence for the Liebman-Sachs on the echo, or did they have to do a transthoracic to see it?
We did transthoracic, ma'am, but in transthoracic we could find only a regurgitation but no evidence of vegetations. But due to lack of transesophageal, we couldn't find the evidence of Liebman's Sachs.
Oh, so she doesn't have Liebman-Sachs.
Yes.
Oh, okay. I'm sorry. I thought that she had Liebman-Sachs. Okay.
Like these, we presumptively kept it as a Liebman's Sachs, ma'am. As because at our center we don't have transesophageal, so new onset it was not there in previously admissions, ma'am. So we thought it's new onset MR, maybe due to vegetation.
Okay, so let me ask you this, and again, I'm going to ask you this from ignorance. I've only seen one case of rheumatic fever in my entire life. Is any of this consistent with her having rheumatic fever? And does she have a history of rheumatic fever?
No, ma'am.
But you don't really know because she hasn't been under medical care
Yes.
previously.
Yes.
So you don't know if she's
We don't.
had rheumatic fever.
Yes.
Okay, and then even the stuff, the infections that she had as an infant, you can't really, no, okay.
So these are pleural fluid analysis and ascitic fluid analysis, ma'am, which were a kind of exudative. But no organism was isolated. No organism was isolated from either of these. And this is our MRI image. Like we have a infarct there.
Right.
Then with the background of these symptoms, other than like after ruling out infective etiology after blood cultures negative turns to be negative, then we send a autoimmune profile. So she had a dsDNA positive, ma'am.
Okay, I see. Okay, so Roland model, Ku is positive. Do you have an ANA on her?
Yes.
Or just a? Okay, so the double stranded is definitely, her SM is, okay, is positive as well, right?
Yes, ma'am.
Okay, so that points towards lupus.
Yes.
And I don't even know, I should know what coup is, but I forgot. Okay. Okay. So then,
our working diagnosis was acute history of multiple organ dysfunction syndrome, autoimmune. May be presented as a flare-up of SL. Like initial presentation is like
well, will be a highly unusual presentation. So, if you go through the diagnostic, the classification criteria for lupus, she certainly has the positive ANA. Oh, I think it's her kidneys you're going to get me on too. She has proteinuria and did she have, you misspelled erythematosus. Everyone does that. You're not unique. But you know, it's, anyway, so when you present it, just do the spelling. Okay, so when you say multi-organ, I would say the other organs are
like she had involvement of her kidney, ma'am, cutaneous, vascular, brain infarct, she had an infarct, and even we thought it as LVH is contributed to lupus.
well. What about the kidneys?
Kidneys, ma'am, we planned for biopsy, but the patient didn't give consent for it, so it was not done.
But you can tell. So did she have proteinuria? And I mean, what was going on with her kid? You can do a lot without.
Yes, ma'am. She had a proteinuria of 24 hours urinary protein was around 2,400 milligrams.
Okay, and how about her? Did she have hematuria?
No hematuria, ma'am. It is
Did she have CAS?
No, ma'am. No cast. Even
So
specific
so other than the protein, it looked pretty good.
Yes, ma'am. Initially, her creatinine and urea were also elevated, ma'am. Then eventually, after starting her on steroids, then it came down to normal.
Wow, well, she's pretty lucky. Did you do an antiphospholipid, or can you do an antiphospholipid antibody?
We are planning to do, ma'am. She is yet to arrive in 2 to 3 days for follow up, ma'am. Then we'll sending it.
Okay, and then her blood cultures were negative, right?
Yes, ma'am. It was the negative. Blood urine.
Okay. And then what was her CBC? Did she have a leukopenia? Because these are all the criteria as well. Did she have a leukopenia, thrombocytopenia?
She had leukopenia and thrombocytopenia at presentation, ma'am.
And did she have a lymphopenia?
Yes, ma'am.
Okay, perfect. So you want to include, this isn't your formal, you're going to present this again, right?
Yes, ma'am.
Yeah, okay. So put all of this in because when you have the classification criteria for lupus and you want to set the stage that she has these other criteria that suggests that you have the correct diagnosis. So those are, I mean, I would put them at the very beginning when you had her labs. I would put also she should have a lymphopenia. It shouldn't just be a leukopenia. It should be a lymphopenia. Did she have that?
Yes, ma'am.
Perfect. Okay. And this is a day 21. Okay. So so you gave her corticosteroids and
hydroxychloroquine, azathioprine was started, ma'am.
okay. And she's doing well?
Yes,
I mean,
ma'am.
so how do you define well?
No, ma'am. Unfortunately, she lost to follow up for a few months. Then again, she presented to us with the signs of meningism, ma'am, without fever.
Oh, this was I couldn't figure this out when you sent me the printout. That's why I said I couldn't figure what was going on. Okay, so she came back. So this is the problem. So there's no means of following her up as an outpatient.
No, ma'am, we were on regular on telecommunication, ma'am, and also like we ordered her back, but they lost to follow up, ma'am, due to some personal reasons at their end.
Okay, let me ask you this, and this is again, actually an area of interest for me. Does she have a cell phone?
No, ma'am.
So you could, okay, so this made it really difficult. Okay, that's all I needed to know. Okay.
Their parents had a cell phone. We could make an audio call and we would talk to them, ma'am.
Okay, that was my question and you answered it. No, unfortunately, I understand the realities of where you are. So that's unfortunately the way it is. Okay, so then she comes back.
He comes
Okay, with
back
headache.
with headache, neck pains, and blurring of vision, ma'am, and diplopia.
Was she still taking the prednisone?
Yes, ma'am. Prednisone dose was currently she was on 20 mg twice daily, ma'am, around 40 mg per day.
And she was still on the azathioprine and the
Yes, ma'am.
hydroxychloroquine?
Yes, ma'am.
Okay.
So we thought of under with the background of this warfare.
Oh
in
no,
this
let me see
country.
your cute slide. You have, let me see the previous slide. I like that. Let me look at, yeah, that was very clever. Let me see. Oh, okay. So you're looking for, okay, so she doesn't have a, oh, that was one of the things I think that they saw on the CAT scan or MRI was a
Yes, ma'am.
subarachnoid.
Yes, ma'am. She had a intraventricular hemorrhage, ma'am. And at this
Yeah, okay.
admission, this was a new observation, ma'am. She had a red color discoloration over her knee. It is discoloration.
Okay, now she's on.
Now she's on warfarin, ma'am.
Pardon?
Warfarin,
She's not,
oral anticoagulation.
okay, but she's also on prednisone.
Yes,
So,
ma'am.
I mean, this certainly looks like an ecchymotic lesion, but I'm going to play the devil's advocate too. You don't know if it's just a plain old fashioned bruise.
Yes, ma'am.
Because between the prednisone and the past history of the warfarin, but she's got that little black spot too. I'm not sure what that is. Okay, so, but she's definitely sick.
Yes.
Is her knee swollen too? Did she have an effusion?
No, ma'am. Effusion was not there, ma'am.
Okay.
So, and she had a features of early Cushing's, ma'am, facial puffiness and buffalo hump.
Right. That's why I said, because that's why she could bruise just from that.
Yes.
No, wait. So her heart looked a little bit better. Okay. I don't know. What's RSBAE? Can you go back in NVBS?
Like,
Pardon?
those are systemic findings, ma'am. Usually we create here for presentation. So respiratory system examination was like bilateral entry was normal, and her breath sounds are unremarkable, ma'am.
No, she can't have, oh, her bowel sounds were,
Normal.
her heart sounds are not unremarkable because she's got the mitral regurg murmur and she has no S3 at this time.
No S3 and murmur also disappeared, ma'am. No
The
previous.
murmur went away? Oh, okay. Okay, I'm no cardiologist. Okay, and her belly's nice. Okay.
So this time CNS examination showed that right side eye abducted, ma'am, with cranial palsy, and all limbs hypertonia was there, as same as the previous presentation also. So
No, go back. You're too fast. You're too fast.
sorry, ma'am.
Okay, so she was hyperreflexic.
Yes, ma'am.
Okay, okay, go on.
So we thought of aseptic meningitis maybe due to intracranial bleed, which was confirmed by imaging, ma'am. CAT scan was done.
Through Google, I guess, whatever. Okay. So why do you think the aseptic meningitis was secondary to a bleed? Could it be secondary to the lupus? And I'm still concerned about an antiphospholipid antibody.
Yes, ma'am. We could have sent it, but she in this admission she didn't have any prior history of fever or other symptoms.
No, you
right?
don't need that. You don't have to have it. Let me ask you this, because a cheap way of looking, it's not always so good. Was her PTT
Yes, ma'am.
and PT, were they normal?
We did it, ma'am. We did, those are abnormally elevated, ma'am. It was her PT was
Oh,
more
because she's
than
on the
1.
warfarin. She's in the warfarin.
Yes, ma'am.
Yeah, okay, because that's still a concern. She could bleed from the certainly. And how bad was her INR that she had the bleeding? Was it very prolonged?
Yes, ma'am. INR was more than 5, ma'am.
Oh, okay. Okay, so yeah, it could have been that. Now, the other thing is, was there any indication that she could have had an embolus from her heart? I mean, you sound like the murmur's better.
Yes,
Um,
ma'am. Even we had an echo, which was problem.
It doesn't matter. I can't read it anyway. I'm a rheumatologist.
Okay. So
I'll take your word for it.
it was showing that even the intensity of murmur when compared to previous admission was also decreased. There was complete disappearance of murmur, ma'am. So likely, unlikely it is due to emboli from heart, ma'am, this time.
Okay. And one of the things I forgot to ask you too, through all of this, was her SED rate or C-reactive protein elevated?
Yes, ma'am. ESR and C-reactive protein was elevated.
And did it
Yes.
come down in the second admission?
No, ma'am. It was still in first admission. It was around 80, ma'am. ESR was 80, and second admission it was 60, ma'am. But C-reactive protein we do qualitative, so it was positive both the times.
Okay, so her labs, and then did her anemia or
Yes, ma'am. Anemia and
leukopenia
leukopenia was improved, ma'am. This time
were
she
improved? Okay, so you're not sure whether this was the lupus or it was from the Coumadin
Yes,
or the warfarin?
yes.
Okay.
So we did anticoagulation, ma'am. She found to be intraventricular bleed.
Right, that's, now the only thing, no, go back, because I think there was some atrophy when I looked at it before. Did she, no, the reading for the brain. No, yeah, the report you have on her, the MRI, the CT.
Okay.
Yeah, the second one. You keep going. Yeah, here, this one.
Yes.
It's. Yeah, why did she's got cerebral and cerebellar atrophy? That's of concern in a 20-year-old.
Yes, ma'am.
So what was the thoughts on that?
Like we couldn't get that ma'am, but we were thinking there was some chronic neurodegenerative disorder underlying to it. But
Well, that doesn't make sense. So did neurology see her?
ma'am.
Did you have neurology? Did the neurologist see her?
Yes, ma'am. Yes, ma'am.
And what did they say about the app? Because that's not what I would expect. I mean, she's only been sick a few weeks.
Yes.
To have all this atrophy is pretty scary.
Like at this time she was an acute presentation, ma'am, so the history couldn't be elicited properly. So now we'll get her back again.
Yeah. Anyway, I found that of concern. I wonder if she has small vessel disease from the lupus. I don't know.
Maybe yes, ma'am.
Yeah, anyway, I would ask the neurologist again to see if they have an
Okay, ma'am.
explanation for that.
Basically, we thought even this APLA also fitting, antiphospholipid antibody also fitting into
Oh,
this.
okay, that's, at least one over again. Oh, this is old. This is from 2003. You can't use this. There's a site called the Lupus Initiative.
Okay, ma'am.
It is fantastic. You should use that, or give me your email and let me send. Oh, the other thing is go to the American College of Rheumatology.org,
Okay.
and they'll give you the criteria. But this isn't, I don't think this is our criteria any. Let me see, I'll look it up real fast and see if I can give you the, in fact, you can get this on your phone. If you go to the American College of Rheumatology, you can download an app that
Okay.
gives you criteria
ma'am.
for everything. Not for everything. Let me see. IgG4. Antiphospholipid. Okay, just a second. Here's. Okay, here it is. Okay, it's okay, I looked up the, I don't think, let me see if it has a prime criteria recommendations. Here's the recommendation. Okay, so you should have the the anti-beta 2 glycoprotein, lupus anticoagulant. Okay, anyway, I would go and look up and get the criteria that we
Okay.
use today. I mean, you're being treated, I mean, we use hydroxychloroquine and all that stuff, but okay, so they should have, I mean, the antibody should be positive, which you can't check.
We'll send it now.
Yeah, and you can't check for beta 2 glycoprotein either.
Yes.
Okay, anyway, I would get a newer reference, and like I said, you can get it for free. It's out there. So it's a shame that you can't. Okay. Okay, so you're saying that this is lupus with antiphospholipid antibody syndrome.
Yes. Yes, ma'am.
It's unfortunate, and her blood cultures were all negative.
Yes, ma'am.
Yeah, okay. I mean, I think that it's unfortunate that you can't, I think that you have a good case. I think it's very nice. And even the brain atrophy could come in there. But I would, oh, do I have your email address?
Yes, ma'am.
That's on there. Okay, let me see if I can just send you, I'll look quickly and see if I can get you the criteria and a few articles on antiphospholipid.
Okay.
And this is a tragic case, I guess, because you're going to lose her to follow up again, aren't you?
Yes, ma'am. And also I'll update all these changes in the PPT and I'll present it again, ma'am.
The what?
I'll update all these changes in the presentation and I'll get you back, ma'am.
Okay, fine. Okay, that sounds, and it's a very lovely, I'm tough on you on purpose.
Thank you, ma'am.
You did an excellent job, but that's what you wanted me for. You wanted me to give you a rough time, so I did.
Thank you, ma'am. Thank
Yeah, okay, it's my pleasure. Okay, so I'll look for these things and shoot them over to you, and then we'll both get back to work. But yeah, very sad case, but good presentation.
you.
Okay. Okay, bye-bye.